years now.
2 years.
So, but before that, I trained for, well, medical school took a total of 10 years maybe, and then, you know, that's including the pre-med. And then I did my residency, both in dermatology and pathology, and then I did 2 fellowships, so that's another 2 more years. So it's been a while. Practice has been the practice itself has been 2 years, but the training before that has been
like schooling.
Yeah, I would say maybe total of 20 years total
20 years?
with the med school and all the residencies and fellowships in between. So it's a long time, huh?
Yeah.
Maybe less than 20.
Why did you choose to be why did you choose to work in this kind of area of science? Why did you choose to become a pathologist, I guess?
Well, it all started with dermatology, my interest in dermatology. I was a dermatology resident then, and I enjoyed, part of our training in dermatology is derm path or dermatopathology, where we look at the skin, the microscopic features of the skin and the diseases of the skin. So I enjoyed that part, so I thought I'd subspecialize in that area, so to do in particular derm path or dermatopathology.
What challenges do you have in your work or in your position?
Okay, so the main challenge is, well, my job is really to make a diagnosis based on a slide. And a slide, when I say a slide, is this tiny piece of glass with the pieces of skin within it. So these are your specimens, and these are taken from the skin biopsy. So they're very tiny, and you have to make a diagnosis based on the microscopic features. So you have to look at all the details, and you have to have seen a lot of these to recognize the pattern. So sometimes you know, it's easy when the features are straightforward, you see cancer right away, but there are cases where when it's hard to decide if it's really malignant or benign. So that's mainly the challenge in making the right diagnosis.
Okay. I know you graduated medical school in Philippines. I kind of researched. As an international student myself, how was the transition? Like, did you have a hard time adjusting to the medical school? Like, changing from a medical school in Philippines to the United States? Is there any difference, or?
There are a lot of differences, but the transition is not that difficult, just because we have more resources here. Back in the Philippines, when I was training, well, Philippines is a third world country, and you don't have a lot of resources there. Patients are, you don't have a lot of patients are poor. You don't have a lot of materials for the patients, medicine. Sometimes you have to, as a doctor, you have to help them find resources to get medicine and all that. But over here, everything is sort of provided for, so it's easier in that sense. But the system is slightly different. The focus of diseases are also different. Back in the Philippines, mostly I dealt with a lot of infectious diseases, while over here, the main things I encounter in my practice here are skin cancers mostly. So there's a slight shift in the focus.
Do you think it's because there's a lot of people with more skin cancer in the United States?
Yeah, that too, and the exposure here is different, the population is different, and people here with fairer skin, you know, with fair skin color have more propensity, or they're more prone to develop skin cancer, so it's slightly higher here.
Was there a specific event or someone who influenced you when you were younger, I guess, to become a doctor?
I guess my main influence would have to be my dad. He's a doctor as well. He's not practicing anymore, but he used to be a family doctor, and I grew up seeing him actually treat patients, and I sort of liked the way the lifestyle of a doctor back then is kind of different. We had a he had a small practice. You know, he had his own clinic. He had his own patients coming to the clinic, and it was not very stressful, I would say. So I thought, that's the kind of life I would like to have. So I thought about doing that. He was my main example and my sort of my mentor growing up. So I would say he influenced me the most.
Yeah. That's really cool because my dad's also a doctor.
And he wants you to be one, or
did I want to be one, I guess, right now. I'm not really sure what.
It's what you see growing up that influences you. So I thought I'd go into it.
What is like the most peculiar skin disease you ever encountered in while you were a doctor and practicing?
Well, I just had one recently, and we have these different categories of skin cancers, right? The big ones like melanoma and basal cell carcinomas. Those are the two main ones, and squamous cell carcinoma as well. So those are separate diseases, and it's each one has its own features. But there are cases that the features sort of merge. For example, melanoma that also has features of a basal cell carcinoma. So it's difficult, and it's fascinating as well, because on one hand you have this one disease of melanocytes, which are the cells that give you pigment, and then on the other hand you have this disease of your keratinocytes, your epidermal cells. So generally they're two separate diseases, but there are cases that these two features seem to merge, and it's hard to recognize them just because they're merging, and that's one kind of very difficult yet fascinating disease that you would encounter. And I had one recently, but essentially you treat them as a skin cancer. You try to go with the treatment of the one with the graver prognosis, so we treat them all as melanoma, just because that's the one with the worst prognosis, and that's more aggressive.
Is melanoma like the most common skin cancer? I kind of was searching about skin cancer and said melanoma was like the most dangerous.
It's the most dangerous. It's the most fatal. It's the most aggressive. However, the most common ones are the non-melanoma skin cancer. So those are your basal cell carcinoma and your squamous cell carcinoma. By far, they outnumber the melanomas. Melanomas, although they compose of less than percentage of those two, their melanomas seem to get more attention or more concern just because they're more aggressive. They're the ones that lead to deaths. So the basal cells and the squamous cells, those are the ones that you can easily, take out, and without any graver consequences. They can metastasize later on, but with less chances than melanomas. Melanomas are the ones that are likely to go to lymph nodes, go to other organs. So that's why we're more aggressive in treating melanomas.
So you can't really cure melanoma?
You can at its earlier stages. So when you see something that's small, and so that's why we're trying to promote awareness. If you see something, for example, you have a pigmented lesion that's growing bigger, that's growing irregular in the borders with different colors. So those are the features that would be concerning for melanoma, and then you go see your doctor, and if they think it is a melanoma, they do first of all they do a biopsy, and then later on they do a wide excision, and if it's early enough, if you take it out completely, then it's cured. So that's the main concern, is when it gets out of the skin, when it goes to lymph nodes. So that's when it's harder to control.
So I know cancer, even after, I know people who they cure it, but then after a few years it comes out again.
Back,
Is that like for melanoma and other skin cancers too?
There are some that do that, and the one of the reasons for that is sometimes these cancer cells, they're very small yet very sneaky. They go down the lymphatics. So lymphatics are your tiny little vascular spaces that go to different parts of the body, and they go to your lymph nodes. So that's why these melanoma cells can escape and can go down the lymph node, and when they get to the lymph node, they proliferate once more, and then So you have metastatic disease there that it may not be evident clinically because you don't see it on the skin, but it's right there, it's growing. So sometimes you discover it later on when it produces more symptoms, and you don't really see it right away because it's not on the skin. So it's dangerous that way.
I know you kind of explained in the beginning, but in order for a person to become a dermatologist, it requires more years of training and schooling compared to other people who's just going to college and then get a job. Were you ever tired or had trouble throughout those years, such as, you know, you went to school for so many years and you were just sick of it, or I guess?
Yeah, there are times when, well, it's not easy, as you know, it's not easy. You have a lot of studying to do. There's so many things to learn and lots of reading, so it entails a lot of reading. But if you're really interested in that particular subject, like I was in dermatology, that's all I wanted to focus on. You get into it and you don't get tired of it just because it's interesting to you, and also you along the way you branch out. For example, like me, I started with dermatology and then I got interested in pathology, so I changed directions a bit, but still, you know, within the very category of dermatology, dermatopathology. So I just, you know, made a little detour and went into pathology, and so it keeps you interested because these are new things to learn. So you keep going, and it's learning as a doctor never stops. You always have to keep reading. You have to be updated with what's new. There's always something new going on, so you have to stay abreast.
So do you still study, like, because there's always new kind of, I guess, skin disease
and new treatments coming out, research. So now, actually now, the trend now is into molecular diagnostics. So instead of, well, not instead, but in addition to looking at skin just by the microscope, you know, just diagnosing through your eyes, there are techniques now that can help you, and these are your molecular diagnostic techniques. For example, you take a piece of skin and you do some molecular testing on it, which would then show you some genes or some abnormalities in the genes that would be typical for this disease, which would then help you in making that diagnosis. So, so this most likely is a melanoma because it has all these chromosomal abnormalities that we see in melanoma. So there are things like that that are coming up right now that are helpful. But and then again, as I mentioned, these are the things you have to maintain and know and learn, because these things are there a few years ago. These are new, and so you have to, you know, keep updated. Yeah, you have to stay up to date with the new technology.
Do you have any research you're conducting right now, or?
So this is a training hospital. So we have actually residents who come train with us. So these are pathology residents, and eventually they'll graduate and become pathologists themselves. But right now we're training them, and they do research with us as well. So right now I'm doing a study or a project with some residents. It's on it's a long title, but it's on fluorescent in situ hybridization.
How do you spell that?
I'll spell it out for you later.
Okay.
It's fluorescence in situ hybridization. It's a molecular technique that we use to examine cells, and these are looking into chromosomal abnormalities basically, and we're trying this technique out on melanomas. So we get a sample of for example, here's so the skin specimens that we get are, you know, they come in formalin bottles. They're very tiny, so they get processed into paraffin slides. So these are paraffin slides, but before they go, or before they come out like this, we have to put them in a cassette or a paraffin block. So this is like wax, you know, like candle wax. So we pour that over it. There's a machine for that, but basically you want to make a block out of this specimen. And then this gets cut. I'll show you the machines later, but this gets cut